Thank you, Vega, and thank you all for allowing me to be here. It's always wonderful to be here every year, and isn't it exciting? I mean, this is what I have dreamed for, you know, so I came into this and I kept telling Judah Folkman, there has got to be medicines that we can use for these patients, and now we're seeing more than one, and I think that we'll have others to see as well. So I have a more simple job. So my job is to really, you heard two beautiful, wonderful talks, and my job is to really, I don't know what to simplify things, or have you feel what we feel when we go in and we evaluate a patient. And have you sort of come inside our brain as medical providers when we think about how are we going to treat this patient? What are the things that I need to think about? And then when we're doing clinical trials, what are the parts of the clinical trial? You heard about 2 unbelievable clinical trials, but how do we come up with that? How do we talk about who should be included, who shouldn't be included? What do we need to do to prove that this works? And what are some other things that we need to consider when we're doing clinical trials? So this is going to be pretty simple, but I want you to come into our brains so that you can see what we think about when we take care of patients. So the only disclosure is that truly there is no FDA approved medicines for vascular anomalies. The only one that is propranolol, and that's been approved for people who have hemangiomas. And so again, I'm going to talk about the role of the medical provider. And remember, we're all medical providers, but particularly the ones that sort of are with you. We're going to discuss a bit about what goes on with a clinical trial. We're going to talk a bit about new thoughts to that, questions about clinical trials, where we go from here. So I sort of have the job of doing a medical smorgasbord is what I'm calling it. You know, kind of summarizing everything and bringing it all together. So when I think about myself as a medical provider, and I think this comes from me taking care of complicated pediatric oncology patients, I see the medical provider, and it doesn't have to be a peds hem-onc person. It can be a dermatologist, it can be a geneticist, it can be a nephrologist, it can even be a surgeon. We think about this person as being that person that really is in charge and rallying the group to come up with a comprehensive medical care. This person or people is the center of this care, and this person is responsible for really organizing the team around this to make sure that a proper care is developed and a proper care is implemented in a very safe way. And so that's kind of what you should all be thinking about is, who is my person who is this medical provider who is doing this? Now, I want to tell you, though, that we all work as a team. So it's not just one person doing this, but there a lot of times is a central person that works with the team of other physicians, of nurse practitioners, of ancillary help, of clinical research people. And that is a person that, again, is in charge of this whole process. And then what really is medical management? So when I come in and when I see a patient and I'm looking at that patient, what do I think of when I'm seeing that patient? So when I'm talking to a patient, I'm constantly thinking about what are they telling me? What are they important? What are they saying is important? What are the clinical symptoms that I need to be listening to? And when I think about those clinical symptoms, I need to think about what I'm concerned about, but more importantly, what I'm concerned about might not be the same thing as what the patient is concerned about. And so that's sort of what a patient is thinking. What are the patient's outcomes that they want to see? So it's really important that in my brain, that's what I'm doing when I'm talking to somebody. And then what are the other factors that I need to think about? So if a patient is coming to me in Boston, where do they live? Do they live in Arizona? And if they live in Arizona, how am I going to implement my plan in Arizona? What do they do? Are these parents that both have to work and I'm going to put them on a therapy that they need to come to see me once a week? So there's many things that you need to think about as a medical practitioner as a whole to take the best care of that patient. We talked about sort of the physical exam. So we heard about symptoms, but what am I finding on my physical exam, and what am I talking to the patient about what I'm finding versus on their physical exam, what are the things that they're concerned about, and do they jive? And if I find something that might be different or something new, it really is me and the team's responsibility to really talk to them about what those things are. So what am I most concerned about? What is the patient most concerned about? And having a discussion to talk about all of this and coming up with a plan, not only an individual plan, but a team plan, but a plan with the patient as well. So what are specific issues, again, when a medical practitioner or another practitioner comes in and they look at a patient? So what's going on in our head? So we talked a lot about overgrowth syndrome. So where is the overgrowth? Is the overgrowth on an extremity? Is the overgrowth more internal? Is the overgrowth near a vital structure? Is the overgrowth something that could be associated with other things? For example, as a kid gets older, could it be associated with something called an arterial venous malformation or something around the spine? So when I'm initially seeing someone, that is what I'm thinking about. The correct identification. So, you heard a lot about PROS and vascular anomalies, but there's many different vascular anomalies, and there's different things that you have to be worried about if someone has a vascular anomaly. There are things that you have to be worried about if someone has a high flow AVM versus if someone has a low flow venous malformation. In venous malformations, you can have problems with your coagulation or your proteins that not only actually help you stop bleeding, but also control your ability to clot. And so you think about that more when someone has a venous malformation versus when someone has others of those vascular malformations. If someone has a capillary malformation and that capillary malformation is in a particular distribution, you might worry about there being a spinal issue, or you might worry about there being something in the head. So when we're seeing you all, when we're examining you, these are things that are going through our head. And also these are things that we also think about if we have clinical trials. Because if everyone is so different, and they are, that was that word that we talked about, heterogeneity, how am I going to prove that a medicine works? Those pictures were pretty clear, but what if we have someone that's not as significant? How are we going to figure out that that medicine is working? So I think about if someone has large veins, I think about if someone's having pain, and where the pain is, and what kind of pain is it. Because someone could have pain because they have phlebolysis, so an inflammation of the veins and small little clots, or someone can have pain because there's impingement, so this vascular anomaly is pressing and impinging on something, or someone can have pain because there's nerve involvement, and that's what's causing the pain, and it's more neuropathic pain. And to me, that helps me and our team because we need to figure out what the pain is and how best to treat it, because all of those different types of pain are treated in different ways. What are the short-term issues? So when I see a patient come in, and it depends on, again, all of those things, what are the issues that I need to address right now? Do I need to address those issues right now? Because someone could come in and they're actually doing fine and developing fine, and someone could come in and they're very, very sick and need help right away. And then it's also my responsibility and our responsibility to think of what happens when that person gets older. So what about females that have vascular malformations in their abdomen and pelvis? What about asking kids about birth control as they get older, or pregnancy, those kinds of things? So as someone follows up with us, we have the responsibility to think of what those long-term issues are so that we can address them at the right time. So what further evaluation needs to be done, and how often should we do it, or do we not know? Do we know that some patients with vascular anomalies can have problems, but we really don't know exactly when that happens? And so is it not then our responsibility to perhaps go back into the literature and see if we can figure out when those problems are happening, or the type of patient that those problems are happening to? And then other issues, the age, profession, quality of life, the goals that the patients have, the hobbies that the patient has. Does this patient want to be a football player, or do they want to be a swimmer? Those are all important things that you have to think about, that we think about when we are talking with you and when we're examining you. So then let's sort of talk about, how do we think about medical therapy? Who needs medical therapy, and medical therapy in general? So when I think about medical therapy, there's different kinds of medical therapy. Sometimes we give medical therapy, and we certainly gave medical therapy in the oncology patients to cure something. We wanted their cancer to be gone. Sometimes we give medical therapy to basically control a disorder. Someone's having clinical symptoms and they're having a poor quality of life, and so we want to control what's going on. We want to control those symptoms of the disorder. Sometimes we give medical therapy because we want to prevent short-term and long-term effects of the disorder, and that's if you really know what those short-term and long-term effects are and when they occur. And sometimes we use medical therapy with other methods of treatment to help with response and to help with those treatments. And then we have to think of, if we're going to use medical therapy, what's the medical therapy that I'm going to use? And we all really truly need to know, how does that medical therapy work? So for example, with cancer, a cancer is a cell that's growing out of control. So in the past, we gave therapy that really just destroyed those cells that were growing out of control, and that's called cytotoxic therapy. But now we know with cancer that sometimes we can modify those cells, and we can sort of give something called precision medicine, where we can check what's going on inside the tumor, somewhat like what we're talking about now, and we can do a better job with taking care of that disease. So do we want to stop the growth of specific cells? Do we want to stabilize the cells? Do we want to help with the surrounding environment? Because sometimes the surrounding environment of inflammation and things like that can create havoc as well. Do we want to control the effects of the disorder by working on some sort of physiologic property that medicine will help us with? So these are all things that we need to think about. And when I said personalized medicine, so people have been saying this over and over again, you see that pathway, and you know that pathway is really a pathway for growth that everyone has said is normally in your cells. And if we know that there's a problem with a certain part of that pathway, then sometimes we can direct the medicine to where the issues are. And the other thing that you have to consider is that not everyone is going to have the same spots of that pathway that are affected. And people also have different ways that they look. That's the heterogeneity. That's what we call a phenotype. How do you look? And we try to correlate the phenotype with what the genotype is. So that's what is that molecular problem that's causing that phenotype. So now I'm going to talk, and I'm going to use, you all have heard about the original sirolimus study that was done. I talked about it here years ago, but I'm going to use that as an example to as well have you kind of open our brains and see what we're thinking about when we try clinical trials. And this has a lot to do with sort of how that PIK3CA came about, and I know that you guys know this, but so back in 2007, I had a patient that had a significant vascular tumor that was made up of abnormal endothelial cells, and those are called spindle cells. And also, this tumor has a big lymphatic component. So I think of it as a tumor and a malformation. And this patient, we had our standards of care that we used for this patient. This is before the era of any genomics. We knew nothing about the genomics of these patients or most of the other vascular anomaly patients. And so this patient went through all of the therapies that were part of our standard of care, and she was not getting any better. And she was to the point where she was in heart failure, and actually every single vessel in her body was dilated. Some of the vessels around her heart and her lung were so dilated they were collapsing one of her lungs. And I really called the palliative care team in because I really felt that I was at a loss and I did not have any other options for her. And so I was thinking about, I had a long talk with her mother, and she said, if you could think of something that perhaps we could go home with and maybe it would help. And so in the oncology world, when we have that, we actually have tumor boards where we discuss patients and we bring up other ideas. And I had been working at Cincinnati Children's with a nephrologist, so with a kidney doctor, about mTOR and the mTOR pathway. And at that point in time, they were using an mTOR inhibitor, everolimus, and we talked about whether that would be beneficial. And the only evidence that I had that it could possibly be effective was that the mTOR inhibitors were being used in tuberous sclerosis patients. I knew that P10 patients, so that is someone that has a germline mutation, they also had vascular anomalies, and that was part of the pathway. And also there's another thing called TIE2, which comes into the pathway sort of over on this side, and I knew that those patients had venous malformations. And so that was my basis for the hypothesis, was that maybe something in this pathway, maybe the PIK3CA pathway was involved, and maybe a medicine in this pathway would be beneficial for these patients. And so when I looked out and tried to figure out what kind of medicines we had available, really the only medicine that we had available was sirolimus, which blocked it here, sirolimus and other mTOR inhibitors. And just as you heard from the last talk, I went to 2 pharmaceutical companies, one which made everolimus, so that was Novartis, and one Pfizer who made sirolimus. And I asked them who would be interested in helping us with this. At the time, no one was interested initially, and so I was able to get sirolimus for this patient. I didn't need, it was compassionate use, but I didn't need to apply to the company because I could order it and get it. But what I did need to do is I needed to discuss it at a tumor board and talk about what my hypothesis was. And then I also needed to write a single patient IRB. So I needed to talk to the internal review board, which is something at every institution that regulates studies. And we talked to the IRB, and they said this person is not going to make it unless you do something. We think that we know the side effects of sirolimus, and they encouraged us to use it. And so I know you know this story, and I know this person's leg was much worse when she came in initially. But this patient also had a significant coagulopathy, and that is really what causes the high mortality in these patients, is they have a profound low platelet count, which is called thrombocytopenia, and they also have a profound low fibrinogen, which is called hypofibrinogenemia. And this patient had a platelet count that was less than 10. Your platelet counts out there, most of you, are about 200,000. Hers was less than 10. And she intermittently was having episodes where she was bleeding. And in 2 weeks, her platelet count became 40,000. And by 3 months, her platelet count was normal. And also her fibrinogen was normal. And then at about 6 months, we really started to see a decrease in her tumor. So that's how sirolimus came about. And then there were other very complicated patients that were in the same situation. Patients that had other types of vascular anomalies. And so what you do as a physician, I did not publish that one patient. I told people about it, but I didn't publish because I really felt that it was too early and we needed to look at some safety of this before we got it out. And we were treating other patients, and we have a rule in oncology that if you treat more than 3 patients with a medicine, you really need to write a formal protocol. So we started writing a protocol as we were treating other patients. I was very fortunate that even if I didn't get that protocol funded, my institution was going to fund it because they felt it was important. So we wrote up a series of patients that we had treated with the sirolimus, and then we actually put together a study. And so I am now going to take you into my brain again and all of the clinical researchers' brains when we think about what do we need to do, or what do we think about when we're doing a clinical trial. So obviously when you're doing a clinical trial, you need a new idea. Sometimes it comes from the fact that you have a patient and that patient has no other options, like we talked about. Sometimes you need to improve on things. So sometimes you need to improve because you need to improve the outcome. Sometimes you need to improve on things because you have medicines, but they have too many side effects, and you want to improve on a medicine that doesn't have as many side effects. Then you have to think about, what are the drugs? What is the drug that I want to use, and what is the basis for that? What's the evidence for that? A lot of times, most people, the FDA and the regulatory centers want evidence. They want animal models, which is why the study that you just heard about is so amazing. But we didn't, for this group, we didn't have any animal models. You have some scientists in the room here that have started animal models, but at that point in time, we really had no animal models. So we didn't have that basis. We really had our hypothesis. So then you need to come up with a hypothesis, and our hypothesis was that the PIK3CA pathway must be involved, and our hypothesis was that sirolimus might help this patient out. But you need a hypothesis for all the clinical trials that you do. And then you need some aims. What is your aim? Is your aim to look at the safety of the medicine? Is your aim to look at how good the medicine works, and that's called efficacy? Or do you know a lot about the safety and a little about the efficacy, but you need to do it in a bigger group of people to do a better study? And we talked about that a little bit on the first talk. And then how do you measure the response? You know, we talked again about that. You all have such heterogeneous groups of disorders that it's not like a tumor. So with oncology, it was easy. You have a mass. You measure the mass because the mass gets smaller. This is more than that. So this is clinical symptoms and the mass might get smaller, and the mass is made of so many different things. And then how do you measure safety? We have a very specific way in oncology to measure safety, and that's what we have been using. It's something called the common tertiary criteria, and it's based on clinical symptoms and what we find with lab work. And usually when someone has a grade 3 or a grade 4 toxicity, that's a significant toxicity, and it is graded. And sometimes when someone has a milder toxicity, but that toxicity continues for longer than 2 weeks and it is interfering with their quality of life, then that's a significant toxicity as well. And then how many people is it going to take to do this study? Because you are doing a study to prove something. So you have to make sure that you have the best of the best ways that you're going to do all this, and you have to make sure for safety reasons that you are following people the right way. And you have to make sure that you're actually not only looking at the short-term effects of this medicine, but you're also looking at the long-term effects of the medicine. And we have learned that so well in pediatric oncology, because we know that a lot of the oncology agents that we have will have long-term effects. Now, oncology patients have no other choice, but we then need to know how are we going to deal with those late effects, and we have to do the same thing when we're talking about these kinds of studies as well. And then where are you going to get the funding to help with this study? It costs money for people to be data managers, for people to do all the regulatory things, for people to do all the writing. It is really expensive to run a trial. And does anybody know how much do you think it costs to run a trial? So say you have a trial and you have 60 patients in the trial, and you're really looking maybe just for safety and the efficacy, because I can do that because that's what the sirolimus. How much money do you think that costs? Anybody can throw any number out. So one was $500,000, one was $1 million, and one was $3 million. And it costs about $2 million to have a study, which you're following for a particular period of time, and then you're doing like a 5-year follow-up. And that's a simple kind of thing, because sometimes there are things that make that study more cumbersome. So that's where this study came into play. So this was the sirolimus study. We decided that this was a phase 2 study, and I have another slide on this, but do you all know, so people have been throwing out sort of types of studies. So a phase 1 study, and phase 1 studies are sort of changing in what their definition is, but a phase 1 study is when you have a new drug and you're trying to determine what the best dose of that drug is. And so in the oncology world, sometimes we don't do this anymore, but we try to get to something called the maximum tolerated dose. And that becomes sort of your dose of that medicine. But we know that for these types of patients, and actually even for oncology patients, more might not be the best. So you might not have to get to a maximum tolerated dose. And sometimes you don't get to that maximum tolerated dose. But that's what a phase 1 study is. It looks at efficacy, it looks a little bit at is that drug effective for the diagnosis, but mostly a phase 1 is to really determine what the dose is that you need. A phase 2 study is then if you have the dose, right? And it was very fortunate for the sirolimus that we had a lot of good dosing from other studies that were out there. But a phase 2 is if you have the dose and you're looking to see what is it effective? Does it work or not on particular types of disorders? So is it a particular type of cancer? Is it a particular type, you could even say, of malformation? And then a phase 3 study is if you know that and you need a bigger number of patients to really see that it works. And a perfect phase 3 study would be if you gave almost half, because there's things called adaptive designs, so you gave some of the patients the medicine and you gave other of the patients something called a placebo, which is like they're taking a medicine but they're not really taking the medicine. And that's sort of the ideal one. But sometimes for pediatrics and sometimes for rare disorders, it's first of all hard to get those numbers. Second of all, it's hard when someone desperately needs a medicine to really say that you might have a placebo. This happened a little bit with the propranolol study with hemangiomas. So we have to come up with different ways, and I'm going to talk about that a little bit, of different ways to study patients. But that was sort of what we were thinking about. What's our aim? What type of study? And then do we want to do secondary things? Do we want to look more scientifically at what are some markers that we can look at? What are some changes in response? The other thing that we talked about is how do you measure response? So, complicated. So as you see, I don't have sort of Klippel-Trenaunay. I like to say what things are. And so these were all the diagnoses that were included in our study. And we rationalized that there was a lot more literature at the time on lymphatic disease than there were on other diseases. So most of these patients needed to have a lymphatic component, except for P10 patients. And they had to have complications because this was the first study, the first prospective study for vascular anomalies. And we really felt that it needed to be done on those most complicated patients because we truly didn't know what the effects would be. And we truly didn't know what some of the side effects would be. So that's kind of what our thinking was. And then we were thinking like oncologists when we made up this response criteria. In oncology, we have very specific response criteria for how something changes on a radiologic film, and it's sort of the percentage of the change, and you can say someone has stable disease or partial response or full response. But then we knew we needed to look at other things, and so we looked at quality of life, and we had standardized ways of looking at that. And then we piloted something called the clinical criteria and functional impairment. So for example, our patient that had the KHE, we actually graded her platelet count and we graded her hypofibrinogenemia and we graded how many blood products she needed. So we had sort of a grading scale for certain parts of that was more of a quantitative kind of a measure. And so we did not, from the get-go, expect to have anyone have a complete response because a complete response to us was that it needed to not be there anymore. And we knew that there would be, we felt that these were congenital problems and they would still be there. And you all know what the results of this study was. And you know that these are some of the results that we had with a person that had a KHE sort of before and at 12 months. And then the skin findings, so again, that was the functional assessment that we did, looking at different types of areas. We had patients that had lymphatic anomalies, and so this child couldn't walk, and then afterwards the bony lesions went away and this child was walking. And we had patients that also had lymphatic anomalies that had significant effusions and that couldn't be treated, that had resolution of their effusions and also their bony disease. And in the patients that had the capillary lymphatic venous malformations, the biggest improvement that we actually saw was improvement in their coagulopathy and improvement in their quality of life. So that's what we think about when we start a study. So I hope that helped a little bit with all the parts of it. There's many more parts as far as the regulatory issues and how do you get your money and what do you do where you are. But now we sort of do need to think outside of the box, because we have to think about our increasing knowledge of phenotypes. I think phenotypes are really, really important because they change how we think about things. It was brought up, if someone has a problem that has neurological implications, you're gonna have you have a different phenotype and you're gonna need different response criteria for that. If you have a patient that has a coagulopathy, you're going to need different response criteria for that. So it's really important for us to gather more information about phenotypes, and this can be done with historical data. And so I think it's really important for you all, if there's an opportunity to enter a registry, to enter registries with the patient support groups. It's really important because we have to learn more about the risk stratification, about response criteria, better definition of the phenotypes, and a more consensus about what we're dealing with. And we talked about this earlier today. So I talked about registries being very, very good at, you can retrospectively, but you can also prospectively look at it. And you can actually do some very neat study design where one of your arms can be looking back into the registry and getting some information there for you to help with your prospective study. And then how do you measure response? I think the biggest thing that we have now that has to do with response, and we talked about, is what do you think is really important to measure? And we have things that are called patient-reported outcomes. And there's actually some validated patient-reported outcomes that have to do with pain, functionality, actually anxiety, depression, those kinds of things that should be included in every single protocol that we have nowadays. And this is an example. This is not related to what we do, but it's out there. So you can go on this website, it's called Promise, and they actually have these surveys for you and you can use them. They actually will even help with statistical support as well. And then how can we use different study designs to really help us? Because we, yes, we can take care of a bunch of patients with PROS, but then if we're trying to figure out outcomes and we break those down into the different phenotypes, how can we use we call it an adaptive trial design to help us with that? Our numbers are small, the diseases are rare, and sometimes we have money restraints, and I think that's also a reason to use adaptive designs. Now, this is a picture now of this even more cumbersome pathway. And what you'll see is that PIK3CA is involved in this pathway, and AKT is as well. And there are medicines that you just heard of, one that is an inhibitor here. There is an inhibitor here. Some vascular anomalies actually are more over to this side of the pathway, and they may need other types of drugs. And so these are our hopes for the future. I mean, it's wonderful that we have more than one drug, but I think we truly need for you all to participate, and really we need for us to know what is the phenotype and what is the genotype. And we need to help all of us figure out how to do that and how to get that so that we know the right medicines to give you. And these are, this is sort of all the questions, the other questions. So, what does compassionate use mean? When do you use it for compassionate use? Who should get a protocol? Who should not? Is a drug approved? Is it not approved? Has it been used in children? Do you have the right starting dose? And we talked a little bit already about phase 1, phase 2, and phase 3 studies. And so in conclusion, it's absolutely wonderful that we have many new discoveries. We have a better classification system, at least for vascular anomalies. We have new diagnoses. We have improved phenotypes. We're getting to risk classification. We're talking about patient outcomes now. We actually have more drug discovery, registries, clinical trial. We're thinking about how can we also deliver medicines in a better way that won't have systemic side effects. So is there a way that you can deliver drugs through interventional radiology, through surgery, as we're doing in cancer? And I think that's going to be a thing in the future. And so I think the really big thing about this is we all need to collaborate. So, you know, there is a lymphatic meeting going on at the same time, and I know that we're collaborating. So we are here with the same mission that lymphatic meeting has, and that's to improve the lives of people that have overgrowth and vascular anomalies. And so we're all in this together. We might have different phenotypes, we might have different names, that might change in the future, that is going to change in the future, but we need to work together. And sort of the question is, you know, you are our heroes. You have taught us about resilience, you've taught us about drive, you've pushed us to make these discoveries and to learn more and to not give up. But we all need to continue to participate, and that means that you all need to continue to participate. You need to ask the questions, you need to join the registries. If you're having a surgery, find out where to send the tissue to have it genotyped. Ask your physicians about genotyping. Get together and think about how you can move this forward. You know, we have a much more complicated system that I can't even get into here for compassionate use. It takes us probably 10 more steps to get a medicine for compassionate use here than it does in France. But how can we push this amazing research forward, and how can we make sure that we're also pushing other research forward, but in the right way, right? It's great that we have this series of patients, but for us all to start using it for compassionate use is not the right way, because we're not going to be looking in a standard way. I mean, it's going to be as standard as we can make it, but it's not going to be looking at it in a standard way, and we're not going to also be making sure that we're following the long-term issues as well. So get together, talk to NIH, talk to the FDA. We all have the same mission. Thank you.